we are looking at the hope innovations that exist in ending HIV/AIDS by the year 2030. Now, we are in 2023, which leaves us with a span of 7 years to be able to have that as a reality, a zero HIV/AIDS country, Uganda. The backbone of it is that the changes in the HIV epidemic, population needs, technologies, as well as virus itself challenges us to rapidly adapt our approach and adopt to new tools, social, technological, as well as scientific innovations, from new medicines and testing tools to innovative community-led approaches and other opportunities have actually been a crucial aspect of the HIV response since the beginning. Access to diagnostics is there, and it's been able to determine HIV infection, and it's one of the major bottlenecks to timely treatment initiation in children as well as in adults. Now, diagnostics for CD4 staging and monitoring. There's also early infant diagnosis as well as viral load screening to monitor viral suppression have been historically offered using complex technologies. Now, many think that in bringing an AIDS-free generation within reach by the year 2030, we need additional options as well as continued investments in other innovative prevention technologies. And what role are these innovations playing in bringing this to realities? Well, I'm joined by Dr. Nelson Musoba, Director General for the Uganda AIDS Commission, to take us through this. And then I'm also joined by Dr. William Tamale, who's a clinical manager at Joint Clinical Research Program, still here in Uganda. Let me start with Dr. Nelson Musoba. Good morning to you, doctor. And what's your HIV status?
Good morning. Well, you're challenging me to share my status publicly, which is okay. I test whenever it is necessary. I did a blood donation about a month ago, and one of the routine tests that are done during blood donations is HIV is one of the screening tests that are done, and my result was non-reactive, which means HIV negative. Yes.
Spoken in doctoral terms. Dr. Tamale, good morning to you, and how is your HIV status?
Thank you very much, Priscilla and Dr. Nelson, for joining us today. My name's Dr. William Tamale, and I bring you warm greetings from the Joint Clinical Research Center. We are located at Lubowa along Entebbe Road, and we are celebrating 30 years in existence, by the way. And wow. The public is invited to come and celebrate with us. We shall have a peak celebration somewhere in October, end of October. Yeah, my HIV status, yes, like Dr. Nelson has shared his HIV status. We also do, at my clinic, we do routine HIV tests. And I invite you, Priscilla, and your team to come over and do your HIV, tests. Mine is luckily HIV negative for now. And I'll continue to keep it like that. So we probably are going to share, on how we can keep, the status quo.
Okay.
Yeah.
All right. My name is Priscilla Regina Naloga, and my HIV status for now is also negative. Why I bring that question aboard? Because for so many people, when they are asked that question, they take it and interpret it as an attack on their life and an attack on their sexual health. And so we want to demystify that with the innovations and the research that has been conducted by both of you. Now, in regards to Uganda as a whole, the status of HIV and the fight against HIV, how much progress has been done as a country, Dr. Musoba?
We've made tremendous progress as a country. We've moved from, a double-digit HIV prevalence in the 1990s, an average of 18%, to about 5.5% as we speak now. We have approximately 1.4 million Ugandans living with HIV. We still have a high burden on new HIV infections. 2022, we working with the Ministry of Health, we estimated about 52,000 new infections. And the majority of this amongst young people, 15 to 24, close to 40% of the new infections were amongst young people, 15 to 24. And even amongst those young people, the girl child takes 1 out of every, 4 out of every 5 of those were females when you compare the the new infections to the males. So we've made lots of progress, and like you've indicated, we are eyeing, the 2030 target, and at some point maybe we need to explain to Ugandans what does it mean when you say ending AIDS by 2030, because many times they say, are you going to kill people living with HIV? Because they'll still be here. So I think at some point we should clarify that. Yeah.
Okay, turning to Dr. Tamale, he'll clarify with that, because I know with the joint research program that you do have conducting of different research, and the research that you have presently clinically, does it state that by 2030 we can be HIV free as a country?
Yes, I know that, for example, Dr. Nelson and the team USC have made bold commitments to ending HIV by 2030, and the ministry has been supportive in this, as well as the government of Uganda, in so many other strategies that they have put in place. But we, of course, follow what the UNAIDS targets are. Previously we had 90, 90, 90. We'll have a conversation on that. And currently we are in 95, 95, 95, the 3 95s. And yes, from the first 95, where you want 95% of people with HIV knowing their status, okay? We have so many strategies that we put in place. We've moved away from waiting for patients to come to the facility. We've, through the guidance of USC, we now go into the communities and do community testing. We mentioned informally here about our self-testing kits. So we need to get to the people who have actually the HIV, okay, and knowing their status and seeing how we are going to, treat them. So we need at least 95% of patients who have HIV to be on treatment, effective treatment, not only treatment, because we do a lot of follow-up on them. And those who are not actually having effective treatment, then we see how we help them. Okay. And the other 95, like we shall be sharing, would be to make sure that we sustain a viral load which is suppressed. Okay. Okay. Yeah. All
right. So, Dr. Musoba, now that requires us to then understand by 2030 that 95 that is HIV living positive, they'll be existing in the next 7 years because of the developments and innovations that have come with treatment. So, what does that?
What does it mean to end AIDS? And you have to be careful when you say we will end AIDS, we will not end HIV. Okay. Because HIV means having the virus in the body. AIDS means having the disease. So the 3 attributes of the definition of ending AIDS by 2030 is we aim to have no deaths related to AIDS. So people should not die as a result of AIDS. If they identify their status, they enroll on treatment early, they adhere to their treatment, suppress viral load, they will not get opportunistic infections, and they will not die as a result of AIDS. So 0 AIDS-related deaths. The second is 0 new infections, which we should have started with, because if, again, people are testing, those who are positive take their treatment. One of the advantages of taking treatment is not just to improve your health, but it's a prevention also. You don't pass on the infection to your sexual partner. So 0 new infections. And then the third is 0 stigma and discrimination, because stigma and discrimination remains such a big issue. It deters people seeking treatment, adhering to treatment, and that is one of the reasons why we see new infections coming up. Absolutely. So once we have these 3, zero new infections, zero AIDS-related deaths, and zero stigma and discrimination. It is the global definition. It's not just a Ugandan definition. It's a global definition of ending AIDS by 2030. Okay. And it's a target, it's a UNAIDS target that all countries have assigned to. We domesticated it in Uganda. We launched the Presidential Fast Track Initiative in 2017, and we are aiming hard to make sure that we achieve that target.
Dr. Tamale, you're nodding your head, but the reality on ground is different to what he's talking about. By 2030, for that to be achieved, that means that present day should have, in terms of data and surveys that have been done, there should be some reductions that we are seeing, but most recent surveys reflect that we're having more infections. More people are being diagnosed and ending up being positive as compared to past times. What is actually causing that?
Well, like Dr. Nelson has mentioned, we've moved from a very long way. I mean, you talk about prevalences of 18% in the 80s and 90s to now a meager 5.5. So that is a good roadmap, if you ask me. And if you're moving in that trend, and supposing that all the strategies that have been put in place are actually working, then we should be able to see the prevalence even going further and further low. Now, talking about the new infections, of course, there's a gap to bridge there, especially the age group that he mentions, okay, the 15 to 24, and the young people. So we need to understand what is driving these new infections. Okay, and therefore there have been so many, innovations that have been put in place. Yes, it's work in progress.
So before we talk about the innovations, what have been the drivers for the spike in new infections?
So the spike in new infections, the drivers are mainly misinformation. Okay, misinformation in this age group. Okay, and they want. Sometimes they have a lot of stigma, which we need to address as well. I've seen a couple of my patients that I actually normally treat when they go to, for example, their secondary schools or university. They hide, they hide to take the medication. Okay, they don't want anyone else to see them. Okay, and of course that's natural, I suppose, but we can see how we can help these people now. Such a person, of course, at that age, university, you're into relationship, sexual relations, risky sexual behaviors, and you're not protecting yourself. Those are, you're going to, infect others. Remember, we have the person who is not taking the medication, the viral load is going to be high, and transmission is going to be very easy. If someone is taking their drugs, we have U equals U, undetectable means untransmissible, okay? So if someone is taking their medication very well, they are almost 99% unlikely to transmit the infection if they have undetected virus, okay? And that is a premise to which we, based on especially for the PMTCT. Okay. If a pregnant woman has undetectable virus, very unlikely that the virus is going to pass on to the baby. Okay. So that is a premise on which we base on. So we need work in progress for that age group that is having very high new infections. Remember what Dr. Nelson mentions, that ending the pandemic means zero
infections,
new infections,
zero stigma, zero deaths.
Yeah.
Okay, all right. So,
but additional risk factors, multiple concurrent sexual partnerships. When Ministry of Health did studies, in 2020, they found that when people were asked how many sexual partners did you have in the last 6 to 12 months, a number of men mentioned up to 7 partners who were not their spouses. The women mentioned up to 4 partners. So if you have multiple concurrent sexual partnerships, especially having sexual partners whose serostatus you don't know, but even to compound that, not using condoms when you're having those sexual encounters. And the other factor is transactional sex. When sex involves exchange of money and gifts, in terms of power of negotiation for safe sex, it tilts unfavorably, especially for the one who is the recipient of money or
And needs the money,
yeah, and needs the money. So you can't negotiate for protection, you can't negotiate for this. So all those factors increase the risks of getting HIV transmitted.
Okay,
Sure.
all right. So under the Uganda AIDS Commission, what are those initiatives and innovations that have actually been adopted to be able to then build up to 2030?
Well, as Uganda AIDS Commission, first of all, we are responsible for policy and strategy. So we call all the stakeholders, we sit down, we say, given where we are now, what innovations should we adopt? And one of the propositions in the strategy that has been adopted and is being implemented is from the prevention side, adopting, the differentiated service delivery models, for instance, to ensure that the health professionals are attending to clients best if they need to be in the health facility. If you go to their entities, for instance, now, unless you have an issue that requires you to come to the health facility, they'll give you pills that last as long as 3 months or even 6 months. And that frees up their time, they are able, but also the client's time, so that you don't keep frequenting the health facilities all the time. The other area that we've had innovations around is just the area of medication, that we've moved from a time when our patients would take up to 10 pills a day to currently the most efficacious pill is available on the Ugandan market, 1 pill per day, no side effects or minimal side effects at all if they are there, and it is easier to adhere. But on the prevention side, for PrEP, Uganda this year approved the use of an injectable for pre-exposure prophylaxis. It means that we have specific individuals in our population who are predisposed to getting new infections. For instance, if you're a couple and one is HIV negative, the other one is positive, you need to keep the HIV negative partner negative. One way to do that is the HIV positive partner should maintain their treatment to suppress the viral load. The negative partner can take on, prophylaxis to ensure that in the event that probably the drug is not working or for some reason the viral load is not suppressed, then they don't get infected. But we have other risk population groups, the commercial sex workers, the multiple involved in transactional multiple concurrent partnerships, because you will not necessarily be in position to control people's behavior. You put a protection mechanism in place, and pre-exposure prophylaxis is one of them. And we've been able to work. I am sure Dr. Tamale can speak a little more. We are also in advanced stages of research for injectable treatment. This has been approved elsewhere, but for Uganda, very specific studies are being done to ensure that our population, to see how our population would be able to respond to that. So just around, but we have a number of other prevention innovations. We have for women the vaginal ring that has recently been approved. That is also a measure for protection. We have innovations around communication. We are trying to reach young people. We know young people communicate differently. They use different platforms. And we are working with young people to communicate to the fellow youth, to see how they can put the message across, and but also working with the people living with HIV, because they live the experience. They know what it feels, to be where they are, in terms of experiencing stigma and discrimination, in terms of how, what they feel when they go to the facility. So we are working with all categories, but taking the fight for HIV, to individual, the media houses, the faith-based organizations, the cultural leaders. It's not just the Ministry of Health, JCRC, or Uganda AIDS Commission that will take this fight and win it by 2030. It's the individuals. It's the media like yourself. It's the households. It's us protecting people close to us, our partners, our children. So we have to own this fight The government will do its part, but as individuals, we need to own the fight so that we are able to...
Research is also doing its part to actually contribute to the fight to end HIV by 2030. He's talked about the research into the injectable as a treatment, but let's also assess the current treatments and preventative methodologies that are presently in the market. I know that there's self-testing kits that are now readily available for people. How have such innovations gone a long way in actually bringing down the prevalence rate?
Thank you, Priscilla. I would like to just mention something little from the history that, you know, Dr. Nelson has been talking about, the pills and now the injectable. But we want to draw your audience to even before, in the 80s. Remember the lady, Nanyonga from Zimbabwe? We started off that bad. From soil, you know.
Yeah.
It was a bizarre situation at that time, very desperate. So we then moved into, you know, the pills, the many pills that Dr. Nelson has been talking about, and just now 1 pill a day, okay? We have the famous TLD that we are using as our first line treatment at the moment. Now, we have also now brought in the injectable. Personally, actually, we had the trial manager come through and talking to your audience about this injectable when it was being launched. Dr. Ivan Chigundu came through and you had a conversation. So we've now done close to 2 years of the research on the injectable. We have cabotegravir and rilpivirine that we're injecting to people, and this is every 2 months. So we are trying to look into the safety and efficacy of this injectable, okay? And the results are promising, okay? This is a trial, so we can't, you know, tell you everything. It's like a police investigation. When they're investigating, they say, we're under investigation. But the results are promising, I must tell you this. And within a year, we shall be, you know, having the results in. This injectable is already in use in the US, Canada, and UK. But we needed to collect our own information here to confirm that actually it can work with us as you know, blacks in Uganda. So that is work in progress, and within a year we'll be able to let out the results, and we know that USC, you know, will take up this information, and we're able to have conversations with the Ministry of Health and how we can actually procure this injectable. So those are some of the new innovations that we are talking about that are coming through. Now the self-testing kit. Yeah, for any epidemic that you want to control, you need testing. Testing is very important to know who is actually affected and, you know, infected. So we have this self-testing kit. We have it free of charge at JCRC. Okay, but can also be found in any pharmacies, okay, especially Frieka and all the other big pharmacies. Those self-testing kits are available, and they're very easy to use, okay? You can use your saliva, and then it's like how a pregnancy test is. So you let it transcend through a small well, and then if there are 2 red lines, then you know you're infected. If it's only 1, it's just a control. It means you're negative. But we say that it's a screening sort of tool, so we need to confirm. So if it's positive, then you may want to confirm with other, you know, tests that have been laid out to us. Okay, so this is just like a very kind of fast screening sort of kit. Okay, so yeah.
All right, Dr. Nelson, giving us your closing remarks on the hope innovations are giving us to end HIV by 2030.
Yes, we as a country, again, every time there's a new technology out there, it is made available to our population, like it has happened for the pills, like it has happened for the test kits. I know that when the injection becomes available, it will be, you know, government will make sure that it's accessible by the population. But while we wait for the injection to come and the cure to come and eventually for the vaccine to come, let's make sure that we practice, we test our status, we know whether we are HIV positive or negative. If we are negative, we strive to remain negative. If we are positive, we start on treatment, because we'll be able to live as productively as possible. So we are all in this together, and I'm sure if we each of us play their part, we should be able to end AIDS by 2030.
Okay, all right. Thank you so much, doctors, for this insightful information, giving us hope at the end of the day that regardless of your status, there's been innovations and solutions that have come into play, and they are modern day responses to what is happening in society, and they are the future to actually aid in ending HIV by 2030. It is possible, but it starts with you knowing your status and responding accordingly. So please find out what your status is today, would be my recommendation. Well, this brings us to the end of Morning at NTV. Thank you so much for having journeyed with us throughout the morning. Given the chills of the morning, we trust that these conversations have given you warmth in terms of wisdom, knowledge, and understanding. My name is Priscilla Regina Denloge, and have yourselves an impactful day.